Hi, I'm Ruben Gobisi. I'm the director of the Cleveland Shoulder Institute. I want to talk to you about the recovery process from a total shoulder replacement. Total shoulders are one of the greatest operations for the shoulder for many patients. And I say that because I do a lot of different kinds of shoulder procedures, but shoulder replacements really have the biggest delta between preoperative function and pain and postoperative function and pain. Many of my happiest patients are patients with shoulder replacement. That being said, the idea in the community is that shoulder replacements are horrid procedures, and that comes from a historical performance of these as relatively new surgeries in the 80s and 90s, where it was much more difficult because of prosthetic design, the way these prostheses were made, and surgical technique having not developed to the point where it is today. Today, I'd say that shoulder replacements themselves are reliable operations as long as somebody has a good rotator cuff and a good socket morphology, or the shape of the socket, which is the biggest factor influencing shoulder replacements otherwise, and how they do. Then they do really well. They're just some of my happiest patients. The recovery of a shoulder replacement is relatively straightforward. In my practice, I use a new technique for reconstructing the shoulder, wherein we repair the rotator cuff, which is often, almost always in fact, released in order to gain entry into the shoulder joint, and then repaired after the replacement is done. And because the repair is the quote weak link in the shoulder replacement, how it's repaired, how that muscle is repaired, is very important. I've designed, along with Dr. Evan Letterman in Phoenix, and Tony Romeo in Chicago, a new prosthesis which is short, minimally invasive, and incorporates the strongest type of repair available for rotator cuff into the actual shoulder replacement. This enables my patients, I think, to move much more aggressively and much more quickly with regards to therapy and progress of their range of motion. And we've been quite pleased with the outcome. When somebody has a shoulder replacement, they typically have stiffness because of arthritis and pain, oftentimes a toothache type pain that's constant and worsens after activity. If they go out and rake the leaves, if they get able to do such a thing, which many can, when they sit in at home for dinner, it's aching miserably, and it's the phenomenon of pay to play. You have to pay afterwards after you do the activity by having increased pain. Sometimes 2 to 3 days after a particular activity, the patient's out in terms of being unable to use that arm. Typically, I'll do shoulder replacements after somebody's failed conservative measures, such as cortisone injections, sometimes physical therapy, and sometimes stem cell treatments once they've run their course. It's another very interesting area for the treatment of arthritis. After a shoulder replacement, which I can do as an outpatient for many people and as an inpatient for some, primarily, and there are many factors, and if you have any questions about or interest in having your shoulder replacement done as an outpatient, please let us know and we'll discuss that with you. Otherwise, the shoulder replacement takes me somewhere between 35 and 45 minutes to do in the operating room, and you go home either the same day or the next day. You can take your arm out of the sling the next day to eat, to drink, to shower, to shave, to dress. In other words, to do what we call the activities of daily living. You'll start therapy about a week after the surgery. The first week, you're just doing activities of daily living as I described. A week after the surgery, you're going to start exercises lying on a bed, getting the arms stretched out. The goal is, over the next 3 to 6 weeks, for you to have pretty good range of motion and markedly improve pain. Usually the pain improvement is pretty dramatic within the first few weeks. The exceptions to this, which are few, are people who come in on preoperative narcotics, such as Vicodin or Percocet, but that's a minority of patients. The majority of patients really are off of heavy-duty pain meds within the first 4 to 7 days, and maybe take it for sleep at night for a couple of weeks. After 6 weeks, I typically stop therapy for most people because they can move their arm pretty well and their pain relief is substantial. The rest of the time, for the next 6 months to a year, they get more and more function, more and more strength, more and more range of motion over time by using the arm. I don't like to strengthen with weights because of the risk of muscle injury during the recovery. And I think that that's something that certainly activities are okay, such as golf at 3 months. You can start. We have a golf program that's also on our website that gets you back into the game over the period of about 8 weeks. We have we love swimming, running, cycling. All of those things are fine by 3 months. In fact, running you could do earlier. So specific activities that you're interested in, please feel free to ask me in the office. Otherwise, I'll show you exactly how I'd like you to recover here in the video.
But you have to do these exercises every day at home, okay? Remember, you want to put about an hour in every day. And how the key thing, and pretty much the only thing I care about in the first 6 weeks, and I mean that, I don't care about any other exercises, this is what I care about, okay? And I hope you understand that I care about it because it matters to you. You're going to start all your exercises in the lying position, okay, whether it's on your bed, couch, sofa, whatever. And what you're going to have somebody do is, and you're going to need somebody to help you, is to support the back of the elbow here like this, and the hand as you see me here. And to keep everything in plane, meaning not out to the side, but in plane, comfortably at the side, just like you would do normally, comfortably at the side, right, and go straight up like that. So the hand is behind the elbow here, and a rocking motion, just to loosen. Remember what we talked about in terms of getting the tendon to be less stiff, just to loosen, and eventually get that arm where it's not hard to do all the way up. Some of you will be really quick with this, and some of you it'll seem painfully slow and tight. Either way, you keep working on it, because what you're trying to do is get to about 140 degrees of motion. Some of you can get to further, but most of you can't. They'll get to about that. That will be excellent, okay? You want to get there by really 3 weeks, sometimes up to 6 weeks, but you want to get there certainly by 6 weeks, because that's how I'll evaluate how you're doing. If I can walk in and raise your arm up like this, which is exactly what I do, at 6 weeks, A+, you can get rid of the sling that you've been in when you're not doing this exercise. You're in the sling, or when you're not doing changing your clothes or taking a shower or something like that, you're in a sling. 6 weeks, if you can do that, you're out of the sling. Your second 6 weeks starts very similarly. You're going to be lying down just like this, okay? And your next goal then is to raise it yourself. Oftentimes I'll have you put a pillow here to start it from this position rather than totally at your side. Start from this position, and then try to raise it by yourself, lying down like this, okay? If you need somebody to help you initially, have your friend or husband or son or kid, whoever, help you do that, and just have an arm until you can do it there. And then really try to hold it down yourself. In other words, don't have them do the same thing you did the first 6 weeks. Have them help you only as much as you need it. So once you get it to there, make them bring you down like this. And then if you need help at that point, they can help you. And then once again, up, and then let go if the person can do it. And then be ready to help as a back down. I don't want you to go out to the side. Not important at this point. The second 6 weeks, all I really want, the second 6 weeks is, rather than me lift it up, I'm going to have you sit up. So you do this for about a week or two until you can get your arm up. Then you're going to sit up, okay? And Janice will show you. You're going to sit up, and you're going to take your hand on the wall and slide it up the wall. You're going to face the wall now. You're not going to go out to the side. You're going to face the wall and slide it up the wall. The best way to do that is take a dry hand towel, okay, and put the hand on, not to walk it. I don't think that's very helpful. Rather, a dry hand towel, and you slide it up the wall. You push it up the wall. It'll easily slide with a hand towel. Once you can do that relatively easily, maybe 3 sets of 10, and don't get too caught up on how many times, just if you can do it until it feels comfortable, okay? And then get rid of it and try to do it in the mirror by yourself, By the second 6 weeks, which is obviously 3 months, when you come in to see me, so I see you right after surgery, within 2 or 3 days you'll see me or one of my PAs. At 6 weeks I'll see you. At 3 months I'll see you. At 3 months what I'm looking for is for you to raise your arm. If you can raise your arm at 3 months, you're doing excellent work. And at that point you can stop therapy. Most of you can stop therapy and start to use your arm for activities as I described earlier in the video, whether it's golf and so on, swimming, cycling, and that kind of thing, you can use your arms. But we'll talk about specifics for your case when you come in the office, okay? But that's how it works. Thanks.